Oh, yeah. Thank you. I appreciate that.
You're muted.
That would help. Good afternoon, ladies and gentlemen. My name is Nathalie Edwards, and I am a member of the Black Advisory Business Council. I will be your hostess for this evening program, Fight for the Cure. Thank you for taking your time out of your evening to join us. The Black Advisory Council is a culturally specific council working to inspire, empower, and promote the economic growth and sustainability of Black businesses and professionals within Washington County. Feel free to contact our council at blackadvisory@wcchamber.org. Before I introduce our guests, I would kindly ask you to mute yourself so we can listen with an open heart and mind to our speaker. We will have a question and answer session, and you'll be able to unmute yourself during this time period. October is a breast cancer awareness month, and many of us, including myself, has had a loved one, extended family member, or friend that has battled breast cancer. The Black Advisory Business Council would like to give a special thank you to Ms. Susan Stearns, CEO of Pink Lemonade, for securing our guest speaker today. Our guest speaker is Dr. Nathalie Johnson, who has spent her career in this fight to eradicate breast cancer. Dr. Johnson is a practicing surgical oncologist and medical director of the Legacy Cancer Institute and the Legacy Breast Health Centers in Portland, Oregon. Her passion to care for others took her to Howard University in Washington, D.C., where she obtained a bachelor's degree in radiation therapy technology. She went on to matriculate at the Medical College of Virginia, now VCU, in Richmond, and completed her residency in general surgery at Los Angeles County, University of Southern California. She spent a brief time in the Virgin Islands serving as the Commissioner of Health of the territory. She then moved to Oregon in 1992 to join the staff at Good Samaritan to assist in the development of breast health centers and advancing the care of cancer patients. More recently, in addition of leadership roles at the Legacy Health System Cancer Institute, she has served on the Oregon Medical Board and the American Board of Surgery as a member at large. Being raised by parents from humble beginnings who challenged her to see a bigger world and to extend love, she has passion to make access to excellent, affordable healthcare possible for all. She believes in dedication, ingenuity, and focus that this can become a reality. Please let's give a warm welcome to Dr. Nathalie Johnson. Dr. Johnson, I'll turn it over to you.
So thank you so much for that kind introduction. And it's really a pleasure to be with you this evening and to talk about understanding the nuances of screening risk and treatment for women of African descent. So tonight I kind of, let's see. Guess I'll do it that way. So I wanted to kind of cover several things, understanding the nuances of screening for both African American and Latino women, to learn about genetic risk assessment and mutations that increase risk for developing cancer, to learn some new and emerging data about something called genomic testing, which is some genetics that we do specifically on the cancer and how that might relate to treatment and outcomes that we see for women of African heritage, and then talk about solutions. So we're here because breast cancer is a significant cause of death. It's the second leading cause of death for women in the United States. Specifically, it's the leading cause of death for Black and Latino women between the ages of 45 and 60. And as we've gotten better with screening and treatment, the mortality from breast cancer has begun to fall, but it hasn't fallen at the same rate for women of African descent. So let's look at that. You know, for all stage breast cancer mortality, you can see that Black women have an 80% survival compared with white women at 89%. And you can see that for each stage, the mortality is not as, or the survival is not as good for Black women as is for white women. So why is that? You know, we think it's multifactorial. So how do we look at the different ways in which African American women may be coming in not at the top of the pile in terms of outcomes? Well, one of the things that we know is that African American women present with breast cancer at younger ages. And this actually speaks to some of the things that we're now recommending for screening. So the US Preventative Task Force did a big study and came out, looking at lots of studies and came out with all these recommendations. And their recommendation was to begin screening at age 50 with mammography, and then every other year after that. But you can see for these green squares are white women, and you can see that their real spike in the incidence of breast cancer kind of peaks at 50 and then goes up. But you can see for every other ethnicity, the rates of breast cancer begin much earlier than 50 years old. So this speaks to, you know, although the US Preventative Task Force is recommending age 50, that is not appropriate for women of other ethnicities like African American women, Latino women, and Asian women. They should begin screening definitely before the age of 50. So how do we talk about screening? Well, when you look at screening recommendations, many of them say if you're average risk, then you should begin at age 40 or begin at age 50, as we were just talking about. But how do you know if you're average risk or high risk? So there's some risk modeling that we do to try to predict that for each person. And how we do that is we look at your ethnicity, we look at your the age at which your period started, we look at family history of cancer, some other things like the density of your breast tissue, whether you've had previous breast biopsies. All of these things factor in to us trying to tell you what your risk, if you're low risk, average risk, or high risk. So we know that the vast majority of these studies, again, women of different ethnicities were underrepresented. So some of the risk scales are not quite on point for us either. The most commonly used risk assessment tool, is something called the Gale model, and that's now called the Breast Cancer Risk Assessment Tool, or BACRAT. If you go online to NCI or you put in breast cancer risk assessment tool, this will actually come up on Google, and you can enter your own information and it will give you your risk score. Obviously, when you go to your provider, there may be some nuances that they can add to get a more accurate score, but it's really sort of a nice, easy to use tool that anybody can do online. Now, the thing with the breast cancer risk assessment tool is it may underestimate the risk of breast cancer for African American women, and it may overestimate the risk for Latino women. And it's not a great tool if you have a lot of family members with breast cancer and other cancers. It doesn't really capture that very well. So that's why, you know, in talking with your provider, you not only need these, but you have to sort of blend everything. The other very commonly used tool is something called Tyrer-Cuzick. This one was actually developed in England, but does a pretty good job of including not only ethnicity and family history, but all of the other factors as well. So it does, I think, a good job of estimating risk. It does a better job than the Gale model at estimating risk specifically in African American women, but does tend to, again, overestimate risk in Latino women. But this is a good tool also to look at, because if your risk is over 20%, you would qualify for additional screening. So I should also explain that what is considered high risk. So the average risk for women in the United States of developing breast cancer is 12% over their lifetime. So a high risk would be if you were over 20% for your lifetime, and that would have us to do additional screening. So there is a tool that was recently developed specifically to calculate risk in Black women, and it's called the breast cancer risk calculator, and it's online as well. So I have up the link if anybody's interested. And it also asks a lot of questions and calculates a little differently based on menarche and the age at which you had your first child. So this is also a good tool, but I personally like the Tyrer-Cuzick and think it does a really good job. So what do you do if you're high risk? Well, there's several opportunities. Many of the health systems do have high risk programs. Kaiser, Providence do for sure. And I obviously representing Legacy. So Legacy's in the house tonight. So I'm going to tell you about our risk assessment program. And so we have availability through either our high risk clinic or our surgical oncology clinic. We also evaluate mainly breast for risk, but through the high risk clinic, you can go if you have a family history of colon cancer, prostate cancer, melanomas, any kind of cancer. If there's a lot in your family, you can contact the high risk clinic and they would evaluate you and talk about genetic risk assessment. I want to also point out that prostate cancer is really a big clue for risk of breast cancer. And we don't do as good a job of men coming in to be tested. But if a man has prostate cancer at a young age, that can be actually the first clue that there's a genetic mutation, and his daughters and sisters may be at higher risk for breast cancer. I don't know if anybody remembers, but Beyonce's dad had prostate cancer and tested and was found to have a BRCA mutation. So that's one of the things that is prevalent in our community as well, but I don't think we always hear that message. So what is genetic testing? So there are different types. I will talk later about genetics of the cancer, but there's also inherited genetics. So what is the risk that from your mother or father, you've inherited a gene that puts you at higher risk for developing breast or other types of cancer? Specifically in African Americans, we have lower rates of genetic testing. I think some of that is mistrust. I mean, I have some patients that I've really tried to talk into having genetic testing because they have a very suspicious family history and they just were not open to doing that. But it's really important because one, it helps us to know how to screen you and other family members. If we know that someone has a genetic mutation or it runs in their family, we do a better job, providers, physicians, nurse practitioners, PAs, of making sure that you get appropriate screening and you start at the appropriate ages. And these things cover not only breast cancer, but we're curing people of like pancreatic cancer, because if we know you're at risk and we're screening, we find it when it's small. So it's really a good thing to do genetic testing and to be aware of it. I also wanted to kind of point out specifically that when you talk about genetic testing, most of those questionnaires will ask if you're of Ashkenazi Jewish heritage, and that's what everyone thought, that they were the ones that were mainly BRCA1 and 2 carriers to begin with. But what we've now realized is that African American women carry those mutations just in the same rate as Ashkenazi Jewish population. So this is really startling. But if you take a Black woman with a new diagnosis of breast cancer who's 45 years old or younger, she has a 26% chance of carrying a BRCA mutation. And the average population for if you tested all women coming in with a new diagnosis of breast cancer, on average, about 14% of them will have a mutation. So you can see that it's almost double the amount if you're young and African American. let's see. Okay. I wanted to share this study because we tend to talk a lot about just BRCA1 and 2. And we also talk about breast and ovarian cancer, but I want to expand our horizons. So this was a study that we published out of Legacy's Cancer Institute. And we had over 2,400 women with a new diagnosis of breast cancer. 900 of them went for genetic testing, and you can see over 800 of them actually did the testing. And we found 14% of them had a genetic mutation. So that was the number I was quoting to you on the previous slide. But what I want to point out here is that there was a high number of BRCA1 and BRCA2 mutations, which is the ones that we see very highly in the African American population. But this gene, CHEK2, is seen just as frequently as the BRCA mutations, and it also codes for colon cancer and prostate cancer. All of these other genes that are listed in red, we see these pretty frequently as well. And these also increase your risk for colon cancer, which is another cancer that we see in the African American population at young ages. So what I'm saying is that if we did a better job of our families being tested, we would know to start colonoscopies, and we would save so many people from colon cancer. I always think about the Black Panther. I'm blanking on his name right now, but he died of colon cancer at a very young age. I don't know if he had any of these mutations, but if family members had tested, then you would know that you should be screening. We see polyps early and we can get rid of them and we can cure.
Chadwick Boseman.
Chadwick Boseman, that's it. Thank you. So we need to be doing a better job of that. So there's been lots of talk about screening recommendations. I've kind of touched on this a little bit already. The U.S. Preventative Task Force has one set of guidelines, and many others have another. But more recently, the NCCN kind of tried to put it all together and come up with best practice. So this is a really good guidelines that I think are important and that is a takeaway. So everyone who's assigned female at birth should have a risk assessment by age 25. That is, somebody should fill out that risk tool and give you an idea of what your lifetime risk of developing breast cancer would be. Is it average or is it elevated? And if you're average risk, then you start screening at age 40. But if you're high risk, then you should start earlier, and you should start 7 to 10 years younger than the youngest person in your family that had breast cancer. So it's to try to clarify that. And this, I'm just putting it up again, that this is from the Journal of the American College of Radiology that notes all women, especially Black women and those of Ashkenazi Jewish descent, should be evaluated for breast cancer risk no later than age 30, so that those at higher risk can be identified and benefit from supplemental or additional screening. So that's key, especially when you develop more aggressive cancers. And we're going to talk about that in just a minute. So when we talk about supplemental screening, mammogram is kind of the gold standard. But if you're at higher risk, then we add MRI or sometimes ultrasound to help us see, because mammogram is not perfect. So if you add those things together, you're so much more likely to pick up cancer and at an early stage. So 3D mammogram comes in different flavors too. And 3D is currently the highest and best technology that we have available. And most of the systems in town do 3D mammography. It's better at picking up breast cancer, especially in dense breast. And it has less callbacks, or, that they see something and you have to come back to clarify. So if you can ask that question, am I having a 3D mammogram? When we talk about enhanced screening, I just touched on that. That would be MRI. And for people that are high risk or have a genetic mutation, we recommend that they have an MRI on an annual or yearly basis. Sometimes we do those together. So we do the mammogram and MRI at the same time, like, you know, if they had it in January, every January. But there are times when we'll do the MRI in January and a mammogram in June, and then the MRI again in January and the mammogram in June, or we spread them out 6 months apart. I do them both ways for my patients. Some people feel like every 6 months, every time they turn around, they're being screened, and they don't like that. They'd rather just do it once a year and not have to think about it for a year. And other people feel more comfortable if they're being looked at every 6 months. It feels like they're being watched more closely. So those are either way works. MRI can be expensive, and some people are allergic to the contrast. So ultrasound is not quite as high resolution as MRI, but it's also a really good addition to mammogram and adds it's good, because if you have dense tissue, sometimes we'll miss a cancer on a mammogram, but between the mammogram ultrasound, we should see it. So it can accomplish some of the same things as MRI, and it's a lot less costly and easy to do. So we've talked about high risk, and to me, I can never go without talking about risk reduction, because there's so much that we can do to reduce our risk of getting not only breast cancer, but other cancers. And I just want to point out that the biggest thing you can do is be physically active. So there was a study done, or actually 2 large studies, that showed if you looked at most people who have a new diagnosis of cancer, only about half of them are meeting physical activity goals. And physical activity means that you get some form of exercise that gets your heart rate up for 30 minutes, at least 5 times a week. So the closer you can get to that, the better. And if you've had cancer, exercising is the #1 way you can reduce your risk of having recurrence of your cancer. It reduces that risk by 40%. So it's not a drug, and it's not a screening test. It's something that you have to do, and it can be dancing, it can be riding a bike, it can be a good walk. You can get physical activity in so many ways, but the importance is to get it. And we do also have drugs for risk reduction. I put that sort of at the bottom because we do offer that, tamoxifen or aromatase inhibitors. And if you're high risk, is something that you can talk to your provider about. So let's transition now. We've talked about screening, we've talked about genetic mutations, and a little bit about risk reduction, but specifically about what's different about breast cancers that we see in African American women. And actually, there are several things that are different about them. So I'll just kind of go over the basic subtypes of breast cancer. So there's estrogen receptor positive breast cancer. That's the best type of breast cancer to have. It usually has the best outcomes, and it can often be treated without needing to use chemotherapy. There are different types of estrogen positive breast cancer. Some require chemo and some don't. Then we have HER2 positive breast cancer, which is a specific type, and it's treated with targeted therapies, but it's a more aggressive form of breast cancer. And then finally, our toughest character right now is called triple negative breast cancer. And this one is far more common in African American women. So you can see here, I just told you about the different subtypes, and the best subtype to have is hormone receptor or estrogen positive breast cancer. And you can see that's far more common in white women, whereas not quite as common in African American women. But when you come to the toughest breast cancer to treat, you can see that African Americans are quite blessed in this category, and which is part of the reason that we see higher mortality rates in African American women. And also why it's really important, because if you have a genetic mutation in BRCA1 or BRCA2, you're far more likely to get a triple negative breast cancer. So screening and picking it up when it's really small, as opposed to when it's palpable and it's in the lymph nodes, we have a much higher rate of cure. So that's why we're focusing on trying to get more genetic testing in our community so that we can do a better job of screening, because we know that if you get breast cancer, it's much more likely to be this. So triple negative cancers, as I just was saying, is I think one of the reasons that we see a difference in outcome, just because we have a higher rate of the toughest breast cancer to treat. So no matter where we see, if it's hormone receptor positive, they come in different grades. You know, I was just saying some of them don't need chemo and some of them do. And then triple negative, but in all of the categories, Black women tend to have higher grade or more aggressive looking cancers. So one of the things that we also think may have happened, why for Black women, the mortality rate from breast cancer is not falling at the same rate, may be around not only triple negative breast cancer, but also around hormone receptor positive breast cancers. You can see right in here, the mortality is falling, but here it's kind of separating out. And this kind of goes along with the beginnings of endocrine therapy, which is what we use to treat hormone receptor positive breast cancer. Whereas before we were treating a lot with chemo and we used a lot of chemotherapy. So this particular study was really interesting. There's a test that does genetics, or what we call genomic testing, on the cancer itself. So doing that helps us to understand if women with estrogen receptor positive breast cancer should be receiving chemotherapy or they don't need it. So I call it, in the old days, we would treat 100 women with chemotherapy to help 35 women. But this test was developed to help us understand which were the 35 women that needed chemo, and then we don't give it to the other women. So once this test was developed, it's been used pretty widely for women with estrogen positive breast cancer. So you can see in the TAILOR-X study, there were over 8,000 women that received this testing for their hormone receptor positive breast cancer. 75% of them were white, 9% were Latina, 7% were Black, and 4% were Asian. But if you looked at all of the categories, the average recurrence score on this particular study was 17 for everybody in each group. 17 for Black women, 17 for white women, 17 for Latinas, and 17 for Asians. And what this 17 means is that you shouldn't need chemotherapy. You should do well without the addition of chemotherapy. But look here, the Black women, even with the same score, didn't have as good an outcome. They had a worse overall survival. And so people question, well, why is that? If we're looking at the genomics of their tumor and it's the same, why would they not do as well? Well, Dr. Hoskins and colleagues then questioned that and did a really big look at this database called the SEER database. So you can see they looked at over 86,000 women that had this Oncotype DX score done. And when they looked at this bigger population, they did see that Black women tended to have higher Oncotype scores in this look. But what was really curious is that the OncoDX for Black women that said they were low risk, they had a lower outcome. But if they were high risk and they got chemo, their survival was the same as white women. So what they deduced was the Onco score was not accurate for Black women if it was low risk. If it came in high risk, then it was fine because we gave them chemo. But if the onco said you were low risk and didn't need chemo, it might not be quite on point. So the end of this study, they recommended or said that the Oncotype DX may need to be recalibrated for node negative African American women. So again, this is women who have nothing in their lymph nodes and should be low risk. They're not doing as well. Well, there's another test that does the same thing. It's called MammaPrint. So I should backtrack and say that the OncoDX was developed in the United States. So of course, you know, in the US, everything's better. And they looked at the genes that we knew about and they added some. So they check a total of 21 genes on the cancer. MammaPrint, on the other hand, was developed in Iceland, and they had all these cancers in the lab frozen, and they just unthawed them and ran all these genetics. And they came up with a panel of 150 genes by which they could tell whether people needed chemotherapy or didn't need chemotherapy. So in MammaPrint, if you come in high risk, you need chemo. If you come in low risk, then you don't. So this was a study that was very interesting because they looked at specifically MammaPrint and Blueprint in African American women. And they looked at 100 patients, and 29 of those 100 patients also had had an Oncotype DX done. And this is really interesting because in 2 of those that they had both done, Oncotype is also known as recurrence score. So that's what the RS means, but it's really onco. So 2 of the patients, the onco said they were high risk and the MammaPrint agreed they were high risk. In 8 of the patients, the onco said they were intermediate risk, but the MammaPrint said 4 of those 8 patients were actually high risk. So then these 4 patients would have been recommended for chemo based on the MammaPrint, but not based on the onco score. And then finally, this is really, I think, the group that is faring the worst. If the onco score said you were low risk, there were 19 patients that onco said they were low risk, but 8 of those 19 patients, the MammaPrint actually said they were high risk. And I think if you extrapolate, that would correlate with why we have women, African American women, that get a low risk score that don't do well. And so I would suggest that MammaPrint is more accurate for African American women. So that's one of the takeaways, is that I currently feel that African American women should have MammaPrints done, or if you're going to have an onco, you should also have a MammaPrint, especially if the oncotype comes in low risk. Then I think a MammaPrint should be a double check to be sure that you don't need to have chemotherapy. The other interesting thing about MammaPrint is they also do, since they do so many genes, they picked up another sequence of 6 genes that they see expressed mainly in African American women, and it's tied to what they call metabolic syndrome. But what it really means is if you're really overweight, then you can have these 6 genes turned on, which also causes you to have a worse outcome. So that's another, back to my exercise and physical activity, we need to do a better job of being fit. So we talked about we need to be screened at earlier ages. So that's one thing that has not been good for us. The recommendation to start screening later has not been good. Then we talked about, understanding risk for us and accurately evaluating our risk. We've talked about genetic mutations and doing a better job of screening and picking up people with mutations so that we understand how to follow them better. And then finally, we talked about tumor biology, and that African American women tend to have more aggressive tumor biology, and some of the testing that we do to delineate which treatments we should be giving may not be quite on point. So we're addressing all of those things. So we have multifactorial reasons why we see African American women dying at higher rates of breast cancer. And then there's one that we have to talk about, and that's differences in racial differences in patterns of care. So what do I mean by that? There was a study that looked at disparities in breast cancer outcomes around the country, and they found that in 24 of the 43 large United States cities, Black women continue to die at much higher rates than their white counterparts. And so looking at that, they're trying to understand, why is that? And it turns out that it's not only the things we've discussed already, but it's also kind of the patterns of care, or how Black women are being cared for. You can see that after this, there were several cities that really did a deep dive, and kudos to Memphis, Philadelphia, and Boston. They've had corrective action. So Black women are now coming closer to survival in their cities, and their patterns of care have gotten better. So we also have data showing that your zip code impacts your outcome. We know that women, not just Black women, but women from marginalized communities or other ethnic communities, tend to take longer to have screening and delays in getting to treatment. And there's some communication barriers that relate to their outcome. So delays in treatment are important, because if you have a delay in treatment of more than several weeks, that can impact your overall cancer outcome. So we really need to do a better job of that. And this is true for, as I said, African American women, but also women from rural communities, and women of other ethnic backgrounds. So we need to be more aware of how we are caring for people. And this particular study was disturbing because it looked at Black women with early stage breast cancer, and 40% of them were likely to receive less than the recommended NCCN and guideline therapy. So why is that? So we're looking at, what should be very good doctors. They're taking good care of people. How are they doing this? How are they not giving Black women the same treatment options, or as aggressive treatment options as they do their white patients? So it's something called implicit bias, and probably everybody on here has heard of it, but I just want to bring it out and talk about it. A lot of people don't feel that it's a real problem, but there's many, many, many studies showing that it is. This is one of my favorites, because this one is pretty hard to explain anywhere else. So there was a ER doctor who did a study at UCLA back in 1993, and he looked at the chance that somebody would get pain medication if they came into the ER at UCLA with a broken bone, with a broken long bone, like either their arm or their femur in their leg. And what he found is he controlled for everything, speaking English, whether they were drinking, whether their blood pressure was low. He controlled for all of those things. And the single thing that stood out for not getting any pain medication for a bone fracture was being Hispanic. He subsequently moved to Atlanta and did the same study at Emory, and the single factor was being Black in Atlanta for not getting any pain medication. So looking at these doctors, if you ask them, do you not give pain medicine based on ethnicity? They would say absolutely not. They treat everybody the same. And yet when you look at the data, that's not so. And the same thing exists in cancer. So this was a study that I found also super interesting. They took 18 medical oncologists that were not Black, and then they had 118 Black patients. And what they did was give all of the medical oncologists an implicit bias test. So the medical oncologists that had the highest implicit bias scores, they looked at their interactions with Black patients and found that they had shorter consultation times, the patients remembered much less of what they told them, and the patients were less likely to trust them and therefore didn't follow their treatment recommendations. And so sometimes when patients have that kind of interaction where they may feel microaggressions in the discussion or feel that the physician is not, I don't know, warm, they don't trust it, so they don't follow through with the recommendations. And sometimes they're called non-compliant, but it may be that they just didn't feel like they could trust the person they saw. What was interesting about this is that once they told those medical oncologists that they had the highest implicit bias scores and their patients were less likely to follow their suggestions and therefore they were less likely to have a good outcome, those medical oncologists were actually able to correct their bias, and they repeated the study later, and the ones that had the highest implicit bias scores on the second study actually had the best patient interactions, and the patients were following their recommendations. So what I think is really a positive takeaway about this is that many providers are just not aware of their biases, but once they are aware, they can correct for it and do a better job. So again, it's part of our society. We all have biases. In the United States, we are fed so many messages about different groups and different people that we all have biases, but we have to remember to control for them. And as a patient, there are ways in which you can actually talk to a team member, whether it's a physician, a nurse, the person who's checking you in at the front desk, about and deal with implicit bias. So unconscious discrimination is the same thing, is that whenever we meet somebody, we make decisions about them right away. When you meet somebody, you know, if you see certain tattoos or they wear their clothes in a certain way or they're carrying certain things, you make all these snap decisions about them. And that's built into us. It's biologic. It's life or, you know, fight or flight. That's how we survive. You sum up danger, stranger, or danger. That's how we're built. And so you do this unconsciously. And so most of the time when people are acting out, it's not because they're consciously discriminating, it's because you make unconscious decisions. So just like looking at this picture of Martha and Snoop, if I asked you who was convicted of a crime and spent time in jail, if you were just looking at the picture, most people would make a snap decision and they wouldn't be correct. So we need to understand that everybody has biases. It's normal human behavior. It doesn't mean the person's a bad person. I make snap decisions about people all the time. So as a provider, I have to think about it. And those are not just on racial lines. You know, if somebody comes in and they're homeless, or they've had a history of drug addiction, or they're very much overweight, all of those things have you treat people in different ways. So we have to be aware of that and think about not doing that so that we can treat everybody the same. So that's growth, and we know that it can be done. So the takeaways from this, from everything I've said so far, I think, is that one, African American women and Latino women should have risk assessment by age 30, and if they're high risk, to begin screening. Genetic testing to look for inherited cancers is really important. 3D mammograms are the gold standard, and sometimes we should add MRI or ultrasound, and that's something you can discuss with your care provider. Be your own advocate. And if you feel like you might be being seen with some bias, one of the things that's important is to help the person see you outside of your group. So one of the things that we teach about implicit bias is to ask specific questions. So as a provider, sometimes I'll say, where does your family hail from, or what's your favorite food, or who's your favorite sports person? Because as a provider, African American provider, sometimes I meet patients who have their own biases about me and whether I can care for them based on the way I look. Will I be as good as another doctor? So I have to cross that barrier too. I think one of my favorite stories is a lady that was clearly from lower socioeconomic background and rural Oregon. And, on the face of it, it would seem we didn't really have very much in common. So when I walked in the room, I could see she was a little taken aback, and she was like, And so then I said, well, where do you come? What's your favorite food? And she said, my favorite food, fried bologna sandwiches. And I said, oh my God, I love those. I used to have those, and we talked about the nuances of crisping the bologna. And next thing you know, we had just the best relationship. And at the end, she said, I was a little dubious when you first came in, but you're so warm and so nice. So it just is overcoming barriers. And as a patient, you can also ask questions. Do you have children, or what's your favorite sports team? That helps the person take you out of seeing you as a group and see you as an individual. And we enjoy taking care of individuals. So tell your story. I think the other thing to know is that there are differences in accuracy of testing. So if you have a diagnosis of estrogen positive breast cancer and they're talking to you about an OncoDX, just ask the question, do you think that's going to be accurate for me? Because I've seen some data that maybe OncoDX is not as accurate for Black women as it is for other ethnic groups. And so it may be something the provider to think about, whether you should have an onco versus have a mammoprint. And remember to always do your follow-up care, and that physical activity is really important. One, it lowers your risk of getting cancer, and if you get cancer, it improves your outcomes. And I think that's it. Thanks for listening. And if people have questions, I'd be happy to answer those.
Yeah, this opens up our question and answer session. So if you want to go ahead and raise your hand in the Zoom using the Zoom icon, or type it in the chat, and we have some moderators that can help us.
Yep, we have one in the chat right now. Susan was asking if you could discuss more about knowing your vitamin D levels.
Oh, okay. So I didn't touch on that, but that's a good and excellent question. So having low vitamin levels of vitamin D increases your risk for breast and actually colon cancer. And African American, actually people that have darker skin shades tend to run lower vitamin D levels. So it's one of the things that I check actually on all of my patients to make sure that their vitamin D level is adequate. And no matter where you live, we mostly spend time indoors, so we don't get a lot of sun, which is where the vitamin D comes from. So it's very easy to be low. So I pretty much recommend some supplementation for most everybody. But if you really want to know, and especially if you have a very rich skin tone, you should probably check your level to see if you're low and how low, because sometimes we have to give people 50,000 units a week for several months to get them back to normal range.
Well, I have a bunch of questions.
Okay.
I lived outside of it, Atlanta, Georgia. And I got my first exam at 35, and had a heated argument with my doctor. Come to find out, too, my mom and a great aunt have had breast cancer, but they didn't get it until their 70s, and now they're spacing my exams apart, and I'm still doing the machine where I'm getting smashed.
Yes.
So I had just had that earlier this year. Should I be changing to the one the mammal print,
Oh,
especially with the dense breasts?
so the 3D mammogram would be ideal, and you can ask because you might have had a 3D mammogram
Mm,
at the facility, so you can ask that question. And
okay,
if you didn't, you should ask them where you could get one, because that is the state of the art mammogram now is 3D.
3D, okay.
And mammoprint is if you actually have estrogen positive breast cancer.
Okay, we have another question in the chat from Samuel. Samuel asked, are there any breast cancer programs designed specifically for Black women?
Currently, not that I'm aware of. So that's why we're doing all this education around how to care for Black women, because there are clearly nuances around it. So part of our role is to elevate and educate our physicians, medical oncologists, surgeons, everybody, our primary care doctors, to know that they need to begin early. So we have a process, and the College of Radiology is doing several articles around that too, to try to help us do a better job of screening Black women as well, and for people to understand that they need to start earlier, and to have a lower threshold of concern.
And I have a question. So in one of your latter slides, it kind of showed a box that had the OncoDX on it.
Yes.
So my question is, are there home genetic tests to test for breast cancer, basically giving anybody like an easy way for them that may be concerned or know they have a family history of breast cancer and want to test whenever they want without seeing a physician, like if you're told you can only go every, you're 35, 40, 45, 50, something like that, an option to give people that want to test a little bit more frequently than what they're being told by the doctor rules or whatever. Is that
So
a product that's out there?
no, currently not. So there was a company online called Color, COLOR, that you could log on and do genetics. And I don't think they have remained viable, but that was really good, because if you wanted to do genetic testing, you didn't have to have a doctor order it, because before, that was one of the things, is the doctor would say, well, you don't really have I don't think you're high risk, because they didn't understand that African Americans harbor these mutations as just as much as Ashkenazi Jewish population does. So you could just get it online, get your own genetic testing. But outside of just routine testing for breast cancer, not really. I mean, so you have to, go in with your provider and talk about all these different things that, that Black women are higher risk, or I understand that, because sometimes you can educate them so that they will say, oh, okay, I see that why you need to have a mammogram at an earlier age, or maybe you need an ultrasound added. So unfortunately, there's no way to just do it yourself. You can, at many centers, schedule your own screening mammogram. So that is possible. There's some facilities that will let you schedule screening. But if you have a problem, if you say, I feel a lump, then they won't do it unless you have a doctor who can follow up on it.
Thank you.
I have another question. Are we still supposed to be doing the self check? They told us like back in the day where you're in the shower, you raise your arm and check check all around, or
So
just are we kind of straying away from that?
So the recommendation from the U.S. Preventative Task Force is that you don't need to do it self-exam, but most of the other societies, gynecology, breast surgery, we all feel like you should check yourself, if not every month, at least every so often, because sometimes you're the one who feels something. And it is possible to have a normal screening mammogram and then, 6 months later, feel a lump and it's cancer. So no one test is perfect. Even MRI is not perfect. Sometimes it misses. So being being aware of your body and checking from time to time is good.
Okay, we have another question in chat from Kimberly. She asked, what is the recommended alcohol intake to reduce and prevent breast cancer?
Okay, so that's a great question. There's been a lot of stuff about alcohol, and basically everything in moderation. So, if you don't drink at all, that's fantastic, but most people like to have a little something. I always refer to the Mediterranean diet, which actually allows, they have a glass of wine once a day, not a huge glass, like a half a glass of wine. And that has actually the lowest risk of cancer, the Mediterranean diet. So having a tiny bit of alcohol or some alcohol in your diet is not bad. But, if you have, a martini in the evening, and then or two, and you do that every day, that would increase your risk. But if you go to a social event and you have a glass of wine or two, and you don't have it again for a couple of weeks, so moderation, so not a lot of alcohol. And there's actually a calculator online that tells you if you're a man or a woman and how much you weigh, how much is a safe amount of alcohol to have, and not increase your risk of cancer. But I feel like that's a lot, and just be conscious, if you're going to have wine, a half a glass is good. If you're going to have 2 glasses every evening, that's will increase your risk.
I'm happy you mentioned the Mediterranean diet, because you had a slide that showed 2 things. It showed the Mediterranean diet, and I believe soy intake, which I'm assuming you mean to increase soy intake. Is that correct?
Yeah, so there's a lot of stuff online that's older data that says that you should stay away from soy, but I never thought that was on point, because the areas in the world where they eat the most soy, they have the lowest incidence of both breast and prostate cancer. So it turns out the way that the earlier studies were done was not on point, and that actually having soy in your diet does decrease your risk of breast cancer. And if you have estrogen positive breast cancer and you have soy in your diet, you have a better outcome.
So my second part to that is that showing or saying something negative about high protein diets, or is it just saying that a high protein diet isn't effective to help fight cancer?
So I think protein is okay. The Mediterranean diet has a lot of like fish and lamb. So one of the things that you have to be careful with a high protein diet in our society, our world, our environment, is that a lot of our meats and things are injected with different hormones, and so you wonder about that. But then you also have to be careful with fish, because there's also mercury and some other things. So having a plant-based diet is not necessarily more healthy either. So I think it's, again, balance. So having good fruits and vegetables, because those are the things that bring the antioxidants, and those are cancer fighting. So having fruits and vegetables in your diet appropriately, and then having meat in your diet is good, and you have a balanced diet. If you're going to not eat meat, then you have to make sure that you actually are getting enough protein in your diet to be healthy. And it's not shown that eating a vegan diet or a vegetarian diet is better than the Mediterranean diet, which actually does include fish and meat.
You were talking about vitamin D deficiency. So when you're getting like just your like a annual checkup with your general doctor, is that something you should be checking for on top of
Yeah,
that?
I would ask about it. Yes.
Do we have any more questions?
Susan has her hand up.
Dr. Johnson, people ask me this all the time. I don't have a good answer. What are additional factors that the average breast cancer rates in the Pacific Northwest are closer to 1 in 7 when the national rates are 1 in 8?
So I think that's a great question. I've always kind of wondered if it had something to do with the vitamin D question, that we have so much more overcast days that we don't get as much vitamin D. That's kind of been one of my working theories.
Okay, thank you.
I believe Jelena has a question for you, Dr. Johnson. No?
Yes. Hi,
Oh,
I'm
yes.
Joanna.
Hi.
Hi. Thank you, Dr. Johnson. We have been so impressed. This is my mother, real fast.
Hi.
Hi. And my cousin's here. So we've all been enjoying this together. My mom's always been really diligent. In fact, I need to be way better. I'm 45 and I've only had one. My great-grandmother, her grandmother had breast cancer, so she was always diligent. However, she does have Parkinson's, and most years she's been good to stand up for the exam. This is the first year she won't be able to. Is there an option that I should ask her doctor about?
So
the appointment
getting an ultrasound is good too, because if there are
Okay.
any small masses, we can see those. So if she can't do the mammogram, we do screening ultrasound so they can look through both breasts. And that's another option.
Thank you so much.
Oh, you're welcome.
Thank you. Her appointment's coming up, and I was like, I got to figure out an option here. So thank you. You really helped us.
Oh, yeah. No, you're welcome.
Do we have any more questions? Going once, going twice.
Okay, well, thank you everyone for listening.
Yes. So yeah, thank you, Dr. Nathalie Johnson. And I see you spell yours a little bit different than mine.
Yeah, I have an H.
Yes, I call that the French, French style. Thank you for your time today. Oh, one more.
Sorry. My mom was coming out with a question. It took some time. She was asking, you did say this, but I think she'd like to hear it from you. What is the minimum age? She's going to answer. Do you think it's good for women to start getting tested?
So I think, that we start usually at 30 if you have a really high risk. There are occasionally families where somebody had breast cancer in their 20s. So if you had a family where somebody was in their 20s, we would actually start sooner. But again, it goes on the risk scale. And again, with genetic testing, if you have a genetic mutation, then we may start at 30 with MRIs and then add mammograms as you get older.
Thank you.
You're welcome.
Okay, so any more questions? No. Oh, Kimberly.
I'm a breast cancer survivor. My mother-in-law was a breast cancer survivor, and I have 3 daughters. And I was wondering if they're probably considered high risk, because I also have breast cancer on both sides of my family with my first cousins on both sides of the family. And I was wondering, my youngest daughter is like 25, and is that too early to get an assessment? Or
no, she can totally do an assessment now, and that would give her her risk scale, and that would speak to when she would start screening.
okay.
And actually, if you want, you can go online and, and fill out that breast cancer risk assessment tool. Again, with the caveat that it can underestimate in African American women.
Yeah, I definitely will do that. Thank you so much. I learned so much.
Okay.
Sorry, I want to piggyback off of Kimberly's question, but do you find that insurance limits assessments or screenings?
Not actually, if you have a genetic mutation or you have a high risk scale, they do more. They'll cover more things. So that's important to remember. And as you're speaking up, I hope everybody heard too, if there's a lot of prostate cancer in the family, that's also a clue for getting genetic risk assessment, because it could mean the women are at higher risk for breast cancer.
Actually, now that's caused another question. I just know just within the Black community, we just don't like getting tested, but it's kind of piggybacking with the insurance and the genetic testing. Is it something within our community just not having enough insurance, or like kind of what you were saying in the slide, just the apprehension of getting tested?
I think there's a little bit of apprehension of testing, because sometimes, it's in your family, but maybe you don't really want to know if you have that mutation. So there's some of that. I do think there's also this fear that if they know I have something, they won't cover things. But actually, the reverse is true. If they know you have a genetic mutation, they'll pay for that MRI. They'll pay for the early screening. They'll pay for, if you also have a risk for pancreatic cancer or colon cancer, they'll pay for, those things, because it's less expensive to screen and catch it early than it is to do all this expensive treatment. And the outcomes are better. It's a win-win all around if you find it early.
So what's considered early, like what to help have a better prognosis of survival?
So for instance, I'll give you a real case. So I took care of someone was referred to me for breast cancer, and I tested her for breast cancer and found a BRCA mutation. It was a BRCA2 mutation, and that's associated with a higher risk of pancreatic cancer. So once she found that out, she shared that with her family. And her brother went and got tested and found out he had the BRCA mutation also. So because we know that, if you're 45 or older, we recommend pancreatic cancer screening. So within, 6 months of him finding out he had the BRCA mutation, he went and got his pancreatic cancer screening. They found a 2-centimeter pancreatic cancer, resected it, and he's done well. This is now almost 10 years ago. But usually people die of pancreatic cancer, and that's because by the time we find it, it's so big, you can't do anything about it. And there are multiple, stories like that we do testing, and then other members get tested and then we find something early, or they get a colonoscopy early and we find a polyp and we remove it and we prevent them from having colon cancer. So I think that's really the important message, is if we know, we can do a better job at preventing, like colonoscopy and getting polyps before there's even a question of cancer, or picking things up early. And I didn't say it, but now too, if you have a mutation, we have targeted drugs that work better to treat the cancer. So, like you have a BRCA mutation, we have something called PARP inhibitors that is really improving the outcome for breast, prostate, and pancreatic cancer, with this targeted therapy that's works for people that have these mutations.
So with that medicine, they wouldn't have to go to the extreme like the actress Angelina Jolie, where she just went and had
Mastectomy. Well, some people, because you have a mutation, some people choose to have the prophylactic mastectomy because they don't want to risk getting cancer, because when we're screening you, we're going to pick we don't prevent cancer, we pick it up early. And some people just say, I just rather remove the risk altogether. But then other people say, no, I want to keep my breast and I'll come and do the screening. And if I ever have cancer, then I'll think about it then. So there are different ways of managing it. Just because you have a mutation doesn't mean you necessarily have to have prophylactic surgery.
You mentioned that a history of prostate cancer could indicate, high risk for breast cancer. Is the opposite true or the reverse true? If there's a history of breast cancer, that there could be a higher risk for prostate cancer?
So yeah, I mean, if there's a BRCA mutation or any, I showed you all those other mutations, some of them are associated with a higher risk of prostate cancer. So again, if we found a mutation in a woman, then we would, tell the family. And so men can also get prostate cancer at younger ages and more aggressive forms of prostate cancer. And if we know, we just know to screen. So yes, the converse is true too. If we found a mutation, it would help us to screen everybody, male and female.
Thank you.
Welcome.
Any more questions? Going once, going twice, 3 times. All right. Thank you, Dr. Nathalie Johnson.
Thank you. Good night, everyone.
Yeah, and thank you everyone for attending today. Please note the Black Advisory Council has a coat drive that begins November 1st. So if you want to connect or participate in the event, please email us at blackadvisory@wcchamber.org. And this concludes today's program. All right, good night.
Good
Night.
night, Dr. Johnson.
Thank you, Dr.
Bye.
Johnson.
Thank you. Bye.
We'd like to get more information.